Dr. T.N. Manohar, Senior Pediatrician from Chennai, and the session will be on updates on growth charts by none other than Dr. Vaman Khadilkar. I request the chairperson and the speaker to occupy the dais.
Good morning, friends. I thank the organizers for giving me this opportunity. Anthropometry is one of the most cost-effective tools for pediatricians to monitor the growth and identify the impairments in growth. This session is on update of growth chart. What is the need for update? Because these growth charts have an evolutionary history of 260 years, and it has been revised many times, keeping in mind with the secular trends, and also to make it more pediatrician friendly so that less time is utilized in plotting the growth chart. We are fortunate to have with us Professor Dr. Vaman Khadilkar, an internationally renowned endocrinologist and a great academician. He was the convener of the Growth Chart Committee of 2014, and also he was the one who has conceptualized and devised the present growth chart of IAP, which has been brought into use from the year 2015. Now over to you, Dr. Vaman Khadilkar, for your presentation.
Thank you, sir, for that kind introduction. Good morning, ladies and gentlemen. The topic given to me is update on growth charts. So I won't be speaking much about what has happened in the past, especially before 2014. A lot of things did happen before 2014, but since this talk is only on update, I want to update you on what has happened from 2014 onwards in terms of anthropometry in India, especially growth charts. So let's move on. Now, as mentioned by Honorable Chairperson, that the history of growth chart dates back to many centuries. Now look at this figure in front of you. This French doctor, Count Mont de Billard, what he did is he plotted growth of his own son from birth till 18 years every 6 monthly. On your left hand side, what you see is very similar to the median of the IAP or CDC growth chart. And on your right hand side, what he also had done, I mean, look at the vision of this man. We are talking about nearly 300 years ago. He had the concept of the speed at which a child grows, because he had observed that children grow very fast in certain phases of life and slowly in the others. So he actually plotted the growth velocity on the right side. This is 300 years ago. I mean, that is really out of the box thinking. Today, if you look at the velocity charts in the world, largely they look the same. So what I'm saying is that the pattern of human growth has largely remained the same. The pattern. The numbers will change, but the pattern doesn't change. It is very evolutionary deep, very robust. Why do you want to study growth in children? Obviously because it is the single most reliable parameter of health and disease in any given child. Hence, it is called as road to health. If you put children regularly on a growth chart, you know which tram line the child is falling into, and if there is a deviation, you can immediately pick it up as abnormal. There is almost no pediatric or pediatric endocrine disorder that will not show aberrations in growth. So whenever a child has a disease, pediatric or pediatric endocrine, it will be shown on the growth chart. So the minute the trajectory starts changing, like you had this discussion for the SGA babies, that as the trajectory starts changing and they become too overweight, before that you should pick up. But you can only do that if you plot it on a regular basis. But most importantly, and as I raised the point with our last honorable speaker about the growth charts, to say that something is abnormal you need to know what is normal. And growth chart is all about depicting normal growth, depicting growth of normal children, children who are not diseased in any given community. So that brings us to this fundamental understanding of references versus standards. Whatever WHO did for children under the age of 5 years are standards. So they are prescriptive, not descriptive. So WHO said, this is how children should grow, provided that everything is under control, which includes maternal health, antenatal period, postnatal period, everything controlled. Then this is how children should grow, which is not the reality in the world, and therefore we continue to have growth references. So references depict growth of normal children growing in the best environment in a given community, given society, given country. These are called references. So WHO itself for 2007 standards has called it references. So for 5 to 18-year-old children, WHO says nobody can produce standards. For children 5 to 18, you ought to have references. So if you go to the WHO website or the manual, look it up, 5 to 18 WHO growth references, 0 to 5 standards. So understand this fundamental difference. 2014 IIP chart committee came up with the charts we all are using now, and the motive was this. Charts should depict the modern data, growth charts which are produced with modern statistical methods such as the LMS. Weight charts should be such that they shouldn't normalize obesity. They shouldn't depict obese children as normal. And the BMI charts were also therefore lowered according to the recommendation of WHO and International Obesity Task Force. And there was also one motive was to simplify growth monitoring. I mean, when I came back to India from England in 1997, I did a survey in Maharashtra, how many pediatricians were actually plotting growth charts. And it was dismal, 1% or less. Today, after 2.5 decades, what has happened? Roughly 20-30% people are now plotting growth charts. That's a significant improvement. That's a significant improvement. And everything has helped, right? WHO growth standards, references, etc. And there was also a motive to produce simplified WHO chart for Indian circumstances. So some of you might remember that we had launched this at GDBPCON 2015 as the IIP growth charts. And if you look at the number of citations that this has so far had, this has 366 citations. These are in the index journals. So this paper has been cited quite a bit. Now these are the 0 to 18-year-old charts. Now what is the update? The actual 2015 charts are 4 folds. There's 0 to 5 on one fold and 5 to 18 the next fold. The trouble is you cannot adjust for the mid-parental height if the child is less than 5 years. So the necessity was to produce 0 to 18 charts so that you could see the family potential. So this was published in 2018. And you all know this simplified WHO chart. This topic is not really for that, so I'm not going to speak about it. I'll skip this. But a word of caution. What happens if you plot even affluent Indian children on WHO growth chart? So we did a study across India, and this is our paper published in 2010. And what we found is even affluent Indian children fare like this. Height is way below the WHO, weight is way below. They're proportionately small children. So they fare all right on weight for height or BMI charts. But if you take weight and height in isolation on WHO, you are going to classify a whole lot of malnutrition even in very normal children, very normal children. Simultaneously, our country has seen increase in the prevalence of obesity tremendously, to a point that from a mere 5% in year 2000, now most modern cities of India are reporting prevalence as high as 30 to 35% of overweight and 10% of obesity across India. So we wanted to define waist circumference charts, because just BMI doesn't help you to recognize metabolic syndrome. Metabolic syndrome is a specific disorder of central obesity. So we wanted to define norms for Indian children, and we therefore wrote this paper in American Journal of Pediatrics in 2014 of the Indian children's waist circumference charts. Indian Academy of Pediatrics is writing the obesity guideline this year, and the paper is in press. So hopefully it will come out before PediCon next year. And in that, we have now used Indian waist circumference charts at 70th percentile as a marker for central obesity in Indian children. This is how they look, and the 70th percentile is the cutoff. If you go to the CDC website and look at the NHA-NES charts, they're much bigger. They're huge. Indian children's waists are relatively smaller, yet the metabolic risk is higher. So national references will definitely help. That's for girls. Now, you all know that Professor J.M. Tanner at Great Ormond Street Hospital in London, where I was trained, produced the first growth velocity charts of the world. Now, they are based on English children. Do Indian children really get that kind of growth? Do they really have the growth velocity? There was no study. So we have now published Indian height velocity norms, and that was published in Indian Pediatrics in 2018. And as you can see here, they are different. What is the difference? The median reached, the 50th percentile is about 3 centimeters lower as compared to the white children for boys, and about 3.5 centimeters lower as compared to girls in India. So you can now use the Indian growth velocity charts to monitor growth velocity of children. On the J.M. Tanner chart, a lot of our children are below the 25th percentile who are actually normal, who are normally growing. One update on this. This year, I think just 2 months ago, we adopted the SITAR model of growth. You may not go into the details of that, but SITAR is a statistical approach that irons out problems related to the LMS method in terms of capturing the highest growth velocity in every single child that you are studying. So we have published a paper on SITAR model for growth velocity, and it's very similar except for the fact that in both genders it has shown 1 centimeter higher velocity. So when you adjust statistically, perhaps Indian children are probably growing a centimeter faster than this in puberty, but for the rest of the time it's very similar to these graphs. Now, do we know the proportions of Indian children? In the Journal of Annals of Human Biology in 2020, our department has published a paper on 5 zones of India and how the proportions differ. And astonishingly enough, it's very close to the proportions of the nation that is immediately next. So if you look at the northeast, the proportions are like Chinese. If you look at the southern part of India, they're very similar in terms of long legs to Afro-Caribbean as well as to Australian Aborigines. That paper is published in Annals of Human Biology, but we have, while doing that, defined the proportions for Indian children, and they are different. We have defined them in 2 different ways. We define the upper segment lower segment ratio, that is from symphysis pubis to floor and from top to symphysis pubis, which is easier in clinical practice, but more scientific is the sitting height percentile. So we now have the sitting height percentiles for Indian children from 3 to 17 years, and they're slightly different to the Caucasian children. But remember, for clinical practice, unless the discrepancy in the segment is more than 2 standard deviations, you cannot call it abnormal. Within 2 standard deviation is normal. We extended the IIP growth chart. Dr. Divya Lakshmi was very elegantly telling you in the last session about what is the cutoff to actually start growth hormone. But how do you know that a child is below minus 2.5 or below minus 2 unless you pull out your calculator, take out the LMS data and do complex calculations? So to make it easy for most of our pediatric endocrinologist and endocrinologist friends, we produce these charts. These are the IAP extended growth charts, where we have shown lines for minus 2.5, minus 2.5, and minus 3. So this makes life easy for people to actually plot and monitor growth. This paper was published in the European Journal of Endocrinology and Metabolism. Now, IAP wanted to popularize growth monitoring, and that still is our motto. We want more and more pediatricians to do growth monitoring, especially height on a regular basis, and BMI. But BMI, height, and mid-parental height involves calculations, and all my pediatricians friends are very, very, very busy people. They don't have time to calculate BMI, they don't have time to measure parents, they don't have time to do the mid-parental height calculations. So, in an attempt to make your life easy, IAP has produced the simplified, pediatrician-friendly growth charts. And here you have two additions now. You have a quick BMI lookup tool, which is in the left upper corner, and you have got the mid-parental height percentile lookup tool. So no calculations are needed. Just to show you how it works, this is the tool, and just look at this. If you have got a child who is 135 centimeter weighing 30 kilos, it falls in the normal range. A kid with the same height, weight 35, overweight. Kid with the same height, weight 45, obese. And a kid with weight 20, underweight. So you don't have to do any BMI calculation. You can now just look it up. So your calculations are eliminated. Similarly, for your mid-parental height, there is a tool provided. You plot the father here, plot the mother, join the two, and in the middle, you get the mid-parental height percentile. So your calculations are removed to make it more user-friendly. What about mid-arm circumference in children older than 5? See, we all have used mid-arm circumference for younger children for diagnosis of malnutrition. That is one age-independent criteria that WHO gave years ago. But when we studied older children, and this was actually a request from the Tata Institute of Cancer Research, that can we develop mid-arm circumference for older children so that we know easily whether our patients who are on treatment with anti-cancer medications are actually improving or their nutrition is not improving. So we, along with the McMaster University, Tata Cancer Research Institute, and one more American university, have produced the charts which were published in, I think it was in the Journal of Nutrition this year. And you now have this mid-arm circumference for older children, where you can actually see what are the cutoffs for malnutrition as well as for overnutrition using mid-arm circumference in older children. These have been field tested. This is a big paper. Then Indian Turner syndrome charts. We as endocrinologists see a lot of Turner syndrome, and we want to monitor their growth on Indian Turner syndrome charts, because Professor Michael Ranke charts produced in Germany are about 6 centimeters taller at all ages. So we have now got Indian Turner syndrome charts which are published in the Journal of Endocrinology and Metabolism, I think year before last, and the brown lines are IAP charts, the blue lines are Indian Turner charts. So you now have Indian Turner syndrome charts. So far our unit in Pune and along with the Indian Academy of Pediatrics have produced these many anthropometric norms for Indian children. So if anybody wants to study any Indian norm in community, you now have everything ready. You just need to get the norms and calculate the standard deviation scores. Now what is the future of growth charts? Now producing growth charts after decade after decade after decade is so expensive. It's a monumental effort. And if you look at the National Family Health Survey charts, they restrict at 5 years. Beyond 5 years, there is no way to know how children are growing. There is no government system to tell us how children are growing. So there is a method which is becoming popular in many countries of the world. They are called as the synthetic growth charts. So as I mentioned right at the beginning of my talk, growth pattern of humans is very robust. The numbers may change, but the pattern doesn't change. So you then have got growth curves which are typical. Globally, children do the same. So what you do then is that you design a global model of human growth, which was first designed by Michael Hermanison, who is a good friend of mine, in 99, and it has been further developed in great detail. And then you plug in the local parameters on the model. So to make your life very simple, what you do is you form an equation based on the global data, you insert India-specific data points on these equations, and then you use the Priest-Benz model or the JPPS model to smoothen these percentile and fit them in human growth model. And then you produce the percentiles. The way to produce percentiles is a little more complicated, and I'm not going to take you on that journey right now. But remember, you only need points at these ages. Birth, 2 years, 6 years for both genders, 12 years for girls, 14 years for boys, 15 years for girls and 18 years for boys. If you have these 6 data points for weight and height, you can generate very scientific growth charts using a little complicated method, which I said I'm not going to take you on that journey, but you get growth charts like this, which are from birth to 18 years, depicting the present reference at a much lower cost, much lower cost. So if you take representative data from 5 zones of India and you take the mean of that and plug it into this system, you get the charts. So we did produce the charts, including the BMI, and published them in the Indian Journal of Endocrinology and Metabolism in 2019. So if anybody wants to know the most recent Indian references on children from 0 to 18 years, the paper is published in the Indian Journal of Endocrinology and Metabolism, or write to me and I will send you. To popularize the growth charts, IAP has its own IAP growth chart application. That's being updated. The new version will come out exactly in 1 month. And we also have lots of templates to calculate Z-scores for Indian anthropometry. Any postgraduate student or any researcher who is interested in studying anything related to children's growth, I can provide you with a template to calculate Z-scores and many other parameters. To summarize what I said, IIP 2015 charts are true representative of today's modern Indian children for height and weight, and a care has been taken not to normalize obesity. These are prescriptive for overweight and obesity and descriptive for height. Large number of norms of Indian children have now been produced and are available for clinical use. Caution needs to be exercised in using WHO charts in Indian children, and the future of growth charts may be synthesizing anthropometry in Indian circumstances. Thank you. So those who want to write to me, that's my email address. Anybody interested in research, please let me know. Thank you.
Thank you, Dr. Vaman Khadilkar. We are immensely benefited by your talk, and also I thank the organizers once again. Now the session is open for question and answers.
Those will be answered at the end of the session. I thank the chairperson and the speaker for that wonderful session on growth charts. Thank you, sirs.
Both these papers. Dr. Bagga and Dr. Manuraj. Manuraj is newer with obesity removed. And in fact, it's slightly easier to read because if you start using the NHNES charts, there what you have to do is to get the percentile of height for American population, which becomes very difficult. These are Indianized, so you can definitely use it. And in fact, just like I showed in my talk about the templates, I even have a blood pressure template. So if you put the gender, the age and the height of the child, you will get the blood pressure percentile. So that has been designed. Sir. Down we haven't yet made. Turner we have made. For the Down syndrome, we are collecting data. Yeah, huge numbers, we just need the national representation. That is still not there. So, we will make it. Yes. No, but they are much taller actually. Much taller.
You are saying for the obesity or the fat is there. What about the muscle mass? Is it in the consideration for the BMI?
See, BMI has many fallacies. One of the fallacies is what you just pointed out, is that if there is a muscular individual, then the BMI will be high, whereas the body fat percentage will be low. So BMI cannot differentiate between obesity and adiposity. For that, you need the waist circumference for central, and if you really want to do more scientific, then you need something like electric impedance or magnetic resonance imaging. Waist circumference is a good marker, and if we really want to look at the adiposity, then even subscapular skin fold thickness is a very good marker.
Thank you, sirs, for the relevant discussion.